los labios.
How do you hear me? Do you hear me okay?
Yes.
Okay.
Yes, I hear you. Good morning.
Good morning.
Sorry.
Okay. So we've got Alfonso. Okay. So it's 10 of us. Shall we wait a couple of more minutes? Oh, we've got Sribala. Hello.
Hi.
If it's okay with all of you, we will wait for another minute and see if someone else joins. I think there's one person maybe missing. Or is it all the group completed? It's 12 of you, right?
Yes, I think.
Mm-hmm.
With Sribala, we are 13.
12 plus 1.
Miss George only.
Okay.
So it's George missing.
Yeah.
Okay. Yeah, we wait for him one more minute. Thanks for being so sharp on time. I really appreciate that. Did you get, in the meantime, we wait, did you get the message, the announcements yesterday that you needed to read the case study of malaria? You can either chat or, so you got it. Okay, good, excellent. Do you have like a WhatsApp group or something? So do you know each other? You're physically in Warsaw.
Only 9 persons in Warsaw right now.
Okay. So you've got a common group and
Yeah.
okay.
Well,
so maybe someone can tell George that we're gonna get stuff. Sorry, Elena. Sorry, Elena, I didn't hear you.
I told we are always at home, but we know each other.
Okay. Good. So we're gonna get started. If someone can write to George, then please let him know we're gonna get started. So yeah, I hope you had the time to go through the malaria session videos. I'm going to share you the presentation so that we can do a little bit of a just as a reminder, if I may, just to show you that the objectives of this session was that you as participants will be able to identify what is a malaria emergency, and to describe, we're going to learn to describe the malaria strategies to prevent or decrease the high levels of mortality attributed to malaria. Do you see properly the screen?
Yes.
So just as a reminder, the way the malaria model was structured, we saw the global malaria burden and the importance of general aspects that we were considering about it. We went through different preventive strategies and curative strategies, and then the malaria outbreaks and how do we respond to them. And today we're going to do it in a practical way through a case study. So this is a document I sent you as handouts yesterday for you to read. It's a real case study in Niger. And we're going to go through the different aspects of how do we respond to a malaria situation like the one confronted in Niger. Any questions about the videos? Any issue that you did not understand that I may clarify to you before we get started with the exercises? Any clarification of concepts, doubts? Nothing? Shall we go on then? Okay, so the first thing we're going to do is we're gonna do this in plenary, right? We're gonna analyze 3 graphs. So I would like you to tell me what do you think about this graph? What's the way? What do you observe? What do you do in this situation? And when would you do it in terms of weeks? So if you look at the data of the two columns in the graph, how do you interpret it?
I think you can see on the graph that the cases were being, a lot more cases were being suspected than they had the capacity to confirm. So maybe there's like a delay in the diagnosis of cases.
So you're saying that there's more suspected cases than confirmed during the first weeks, right?
Yes.
And what do you think does that mean?
I thought that maybe their capacity to diagnose cases and process tests might be a bit slow.
Exactly. So they are treating malaria cases without confirming it, right? Through the testings. Yeah, during the first weeks.
Yeah, I think so.
Okay, any other ideas in the graph? Thank you, Sinet.
Yeah, maybe I can add something to it. On top of what Sinet said, like if you see the graph, the orange color shows the total number of malaria cases that were suspected versus the white one shows the confirmed cases. Meaning either they might have done RDT or microscopy for confirmation. So in the initial week from 21st to around, like, let's say until 26, the number of tests was less in compared to, or they might have just given the medicines for the suspected malaria. And when it came to 27 and until 31, 32, then they have started like really making detection by microscopy of RDT, and then have started treating likewise. And the other thing is, what we could say is there is sudden increase in the number of cases from let's say week 31, 32. So I think like if we were in the place let's say 31 and 32 week, then we should make some kind of investigation whether or not it's really going to be an epidemic or not.
Thank you, Ram. Very valuable inputs. Any other interventions? So absolutely. So if you see the first weeks, as Ram and Sinet were mentioning, there were, and this is always we do hypotheses when we see graphs like this, so that we need to start investigating what happens when you send this, for instance, to your colleagues in the other side of the people that are monitoring the projects, let's say, then they need to know the answers of what is the discrepancies in the different graphs. So yeah, one of the hypotheses may be that the suspected cases were treated without an RDT or a microscopy confirmation. In the OPD, normally we will do RDTs, rapid diagnostic test, the faster, 15 minutes to perform and quite straightforward. So maybe they had a lacking of test, or they did not have enough training to perform the test, or there may be very different issues behind that, and we need to investigate. And then from week 27, for instance, the training was done, and then the RDTs were available, and they could do the confirmation of the cases and treatments accordingly. If we don't do the confirmation, then we may risk that we are treating cases that are not malaria. So we may be treating children, for instance, that are not malaria, and they may have other diseases, and some children may die of other causes because they've been treated for malaria and they had a pneumonia, for example. No, so these things are very important, that we do things properly in terms of case management. Then, if you go as Ram was mentioning, there's an increase of cases from week 30 to 31st. Then you start seeing the increase, and this is what Nuria was explaining you these last days. No, when we follow the pattern of the outbreaks, you need to see week by week and see the trends, and then you need to compare it within the context, if this is normal or abnormal, depending on the previous years or depending on the context where you are located. So yeah, the cases are duplicating on week 32, then duplicating again on week 33, and so on and so forth. So that's the logic of that graph. Then if we go to the second graph, I will give you 1 minute to think about it, and then provide some hypothetical reasons. What do you think about this graph?
The first thing I would say is, I guess we need to compare with the previous years, but we start at week 21 with almost 20% of positivity, which seems quite high. Also, there's a rapid rising starting week 30, which might indicate an epidemic, since it's almost 40%. It ends up above 80 in 5 weeks. And yeah, that's my input.
Thanks, Julia. Any other interventions? Do you know what the RDT positivity rate is?
I think the positivity rate is the number of real positive malaria cases divided by total number of total number of RDT tests that you carried out. That could be expressed in percentage.
Yeah, exactly. So if depending on the week where you are, then you may think this is normal or abnormal. As Julianne was mentioning, you've got 80% of positivity rates in this from week 34 up to 35 and 36 and so on. And that's quite high. So indeed, so just to highlight that there's starting an increase of RDT positivities, and we need to then see what is happening. And we need, of course, to compare this, if this is an unusual pattern or not, before we actually say that this is an epidemic, because maybe it's a normal trend of the seasonality of the country. So we need to take these aspects into account, yeah? The rains, the patterns, what are we confronted with? And in any case, 80% of positivity rate, it's very high when we are talking about external consultations, and this we can do monitoring screening activities of malaria that we do normally in nutritional programs and in antenatal care services. So this is a way to monitor trends of positivity rates. So just to develop a little bit on this, when you have nutritional programs in malaria endemic areas, what you do, systematic screening to the children that goes into the nutritional programs on admission. And this is the way you know how many children have malaria, even though they don't have the symptoms. Normally, we follow the case definition, just as a reminder of fever or history of fever in the latest 48 hours. And then that's the criteria to perform the test. But in nutritional programs, since the malnourished children have the low immune system, normally they don't develop this fever. So we do a screening of all the children to detect the parasites in their bodies. Therefore, we do an RDT on admission to all the kids. And this is the way we can monitor the positivity rates in our programs, and also for pregnant women, that they may not develop symptoms, and then they go to their consultations in the antenatal care services, and they are tested systematically for malaria, because they may have no fever either. And then we can monitor these trends. So we use these programs as sentinel sites to see the positivity rates if something is going wrong or right in the consultations. So this can help us also to have more additional elements in terms of monitoring and surveillance. Is this clear?
Sorry, Nina, you said
Yes.
that malnourished children, maybe they don't get this fever, but is it because of something specific, or?
Yes, it's because they don't have developed the immune system enough. So sometimes their bodies is not reacting properly to the infections. So they may be asymptomatic, but they have infections in their bodies. This is why they're so vulnerable, because their body is not reacting properly to the infection. I don't know if Nuria, you want to complement?
Okay, I understand. Thank you.
No, you did perfectly. You did perfectly, Nines. No more comments.
So that's why we do a screening, systematic screening to the malnourished children, because they may look okay, but then if they have malaria, that's very risky for them, and we need to treat them immediately, even without symptoms, yes, to get rid of the parasites. Okay, so third graph. What do you think of this graph? You've got the children under 5 and the children over 5. What do you think?
Like you just said there, the rate of growth for children under 5 seems to be a lot faster than over 5. So maybe this would indicate if there's a lot of malnourishment in the area, maybe it would indicate that the screening process for infants isn't adequate enough.
Okay, other interventions?
I'm not sure. Maybe now that we know only the number of the case, maybe we need to calculate the attack rate too between these two groups.
You need to calculate the attack rate of these two groups. With what purpose? Gear?
So we can we can know how, you know, to compare the outbreak between these two groups, and we will know where we can prioritize.
Okay, so in all epidemics, we should really calculate the attack rates per place and per age groups. So to make operational decisions, right?
Yes.
Any other ideas? What are the trends here as well?
Nines, one question in the chat.
Oh, sorry, did not see the chat. Don't see it. Let's see. So I've got it. Okay, you've got, okay. Proportion of malaria cases in children less than 5 can be an indicator of a malaria emergency. This is a question. Thank you, Srivala, for the question. What do you think? Is it a normal trend to have more malaria cases in under 5s or not normally? I'm asking it to the rest of the colleagues and see if they can answer to the question.
I think yes. As you mentioned that they have weak immunity compared to the adults. So it makes sense, I guess.
Yeah, we will come through that, but I will come back to the map I showed you in the videos. But normally in sub-Saharan African settings, the under 5s are the most vulnerable. Remember the global burden of malaria? It's majority of the cases that are dying in Africa today is the under 5s population. So for sure they are the most vulnerable because their immune system is lower. But when you see all the groups affected, then this is, remember one of the exercises you were doing in the videos of what are the target groups that we may focus at in malaria emergencies or epidemics is because other groups are also affected. Yeah. So in emergencies or malaria epidemics, then we need to really focus what is the target population if all the groups are affected. Because if all the groups are affected, is because we need to think about other triggering factors that led to these groups may be affected. Like we said, in malaria big epidemics, when you have overwhelmed capacities and the structures are completely collapsed, then you can see adults and children over 5 having malaria as well. Is that clear?
May I ask a question here?
Of course.
Yeah, so in that case, do we prioritize the children under 5, or we just go to treat the whole population at once? Like we do the intervention for everyone?
If we are confronted with a big emergency of malaria which is affecting a specific area, children under 5 and children from 5 to 15, then we need to respond to the whole population. Yeah. So this is why we need to know the splitted data, and we will go through that along the case study. Okay.
Yes, thank you.
Did I answer to you, Sylvia?
Yeah, yes.
So it's very important to really gather the data of the different age groups. Yeah. Okay, so again, there's an increase of cases, the same ways we saw in the latest graphs. And you see that the under 5s are higher, but still you have a huge number of over 5s. Another thing to take into consideration in this specific graph is that sometimes countries decide that due to the vulnerability of children under 5, they have free access to healthcare, whereas the older groups, like over 5s onwards, they need to pay in a cost and recovery system. So sometimes they are blocked of accessing health structures because of monetary aspects. So then you have a bias in the data collection, and we need to take those elements into account. This is why we need to understand how the health system works in a country, okay? So maybe we have an increase of cases of under 5s because we have an underreported cases of over 5s because they did not have the proper access to healthcare. Yeah, so we need to further investigate things. Any questions? Okay, I don't see any questions in the chat, so we're going to move forward. You've got the case study of malaria, Busa district. This is placed in the Tawa region of Niger. This is in the area of bordering Nigeria. This is an area where you can see, do you see my mouse? This is Busa district, which is close to Madawa district, also in Niger, and this is the hyperendemic area of malaria, and you see Busa is located in the mesoendemic areas of malaria. So this is meaning that you have a transmission pattern in the country around 4 to 6 months of the year, having 60% of all the cases yearly distributed along these months. So from the month of June up to October, November, and December is when you have the big seasonality of these malaria cases. All right? So if you read all the different aspects of the text, I'm going to ask you to analyze and interpret the findings of this assessment, because this is an assessment done to make operational decisions. So this analysis that you're going to do, and I'm going to break you in groups now, must consider remember the steps of the outbreak investigation and the exercises you did with Nuria, the magnitude and severity of the situation, then compare these indicators, the vulnerable groups to malaria that we've been mentioning before, and the high risk and aggravating factors for an emergency to happen, and the local response capacity. So take these elements into account, and then think about, and I will leave this slide so that maybe you can take a photo of it for the group work. And then in a maximum of a half page, write your conclusions of your analysis and the interpretation, so that the people in the headquarters can understand the situation. Think about the 4 questions we always ask to you, like, is this an emergency? Does it need an intervention? Does MSF need to intervene, or what do we want to achieve? Yeah, so I'll go back to this slide so that I'm going to break you now into the break rooms. And I'm going to give you 15 minutes to write your conclusions, okay? And we will discuss in plenary your conclusions. A ver.
Nines, you have the breakout rooms option?
Yes, I was looking for it, and
Because
I need to, because it's all in the same room now. So breakout rooms,
yeah, breakout rooms.
close all rooms, and I'm gonna add rooms, right?
Yes, and then you put 3.
Rename. So I'm building up the groups, huh? Sorry. Okay, so I'm gonna distribute you in 3 rooms, and I'm gonna, but they are not assigned. Okay, so I need to assign you.
I think it's okay now, because
Yeah, but I need to assign the people, right?
if you do it
Randomly.
automatically, no.
How do you do that now? Let's see. Assign automatically. Okay.
Yes, exactly.
Okay. Okay, the rooms are opened.
Okay, now.
Vale.
Perfecto. No te
¿Las
salía.
cierro?
No te
Las cierro. No me salía, tía. No me salía cuando estoy haciendo la presentación, no veo el breakout rooms. He tenido que dejar de compartir la pantalla para verlo. Porque me iba arriba, donde están los puntitos, y no me salía breakout rooms.
Vale.
Todo más.
En cambio,
Bueno.
a mí me salía, que antes no me salía. Bueno, en fin. Vale, pues
Bueno.
ahora ya solo es eso. O sea, tú ves que te salen los grupitos y en las rooms puedes, si te mueves por allí, ves que podrás join.
Entonces puedo entrar en las breakout room 1, 2, 3. Vale.
Entonces ahí vas moviéndote tú misma y le vas preguntando, bueno,
Vale.
cómo van y tal.
Vale, guay. Guay. Oye, se ha escuchado mucho a Blanca trasteando arriba y abajo.
No, no se escuchaba nada, lo que sí que se ha visto.
Se ha visto que entraba.
Sí.
Le he dicho Blanca. Digo, Blanca, no esté por aquí porque la avisé, ¿eh?
Ah, vale.
Y he estado aquí trasteando y he puesto el mute un momento y he dicho, Blanca, sálgase de aquí.
No se ha oído, no.
Vale, pero yo la estaba oyendo, entonces yo me estaba poniendo nerviosa. ¿Qué tal?
Bien, bien, perfecto.
So far, oye, son monísimos, son listos.
No, muy bien. Vale.
Vale, guapa, pues muchísimas gracias por el coach.
No, si no he hecho nada, cariño, al contrario, he aprendido. Bueno, de momento lo voy a estar un rato por aquí, lo dejo con mute y stop vídeo, cualquier cosa.
Vale.
Pero, porque ahora les tienes 15 minutos, ¿no?
Ahora 15 minutos, sí. A ver, discusión, voy un poquito, case study, sí, voy un poquito retrasadilla.
Vale. Y ahora ya siempre van a ser los mismos grupos, entonces simplemente es, ya vas a ver que vas a tener que jugar con, no sé, te sale allí, ¿no? Como ir a los grupos, ¿no? ¿Cómo es cuando vuelves a hacer los grupos? Sí, bueno, le vuelves a dar. Creo que es lo mismo, creo que tienes que hacer lo mismo. Sí.
Bueno, ya me apañaré.
Y si les quieres
En
mandar
realidad son dos ejercicios en grupo.
Vale.
Y,
si les quieres mandar un mensajito, ahora verás que cuando te sale ahí, verá que pone...
broadcast a message to all.
Eso.
Y que les digo, ¿tenéis 10 minutos?
Por ejemplo.
Vale. Pero I'm gonna sneak in, a ver si tienen dudas.
Sí, exacto. Sí, porque siempre les quedan dudas de qué tienen que hacer. Vale, guapa. Yo estoy
Vale,
por aquí
reina.
todavía. Suerte.
Ok, perfecto. Venga, hasta ahora. Are you all back? Okay, so we're going to do this in plenary because we don't have so much time. So I would like to hear from all the groups major lines of the situation of the context. I mean, for me, it's to start with the conclusions of the three groups first. So group 1 tells me the conclusions, group 2 and group 3, and then we will wrap them up together, okay? So group 1. We have a representative of group 1. I didn't explain you this, sorry, but maybe we should think about someone to present the conclusions, general overview. Are you with me?
I think, Nina, sorry, I think maybe we don't know the number of the group. Maybe you can mention someone that was in the group so that we know which group.
Oof, wait, then.
Oh, I don't know. Like at least, I don't remember the number of.
That's okay. And randomly, whatever groups you were, then one of you, because I don't know now the splitting of the groups, not to miss time with that. So whoever was with you, Victoria, in your group, maybe you can start.
Okay.
Okay. So it was all a bit. We were a little confused, but so what we found out, or like what we were saying, is that we came to the conclusion that it is an emergency. One of the main reasons was because there hadn't been an outbreak in the previous years. And that's why we thought if there hasn't been any outbreak before, then the likelihood that it actually is an emergency is quite high. And then when we looked at like the different factors, we saw that it does need intervention, and it needs intervention from us. Just because one of the main things was that for the hospitals, there was no real access to the rural areas. So all of that population was kind of left out of treatment, or they had to walk quite far to get somewhere. Then the staff was undertrained, and the quality of cases confirmation might not have been very accurate either, because they didn't have enough testing, or the testing was expired. And then we also took into consideration that there was quite a situation with malnutrition going on, which means that the population below 5 years old was quite vulnerable. And it said that in the hospitals there was a 12% mortality rate. So we thought that's quite high.
Okay. So your conclusions is going through these elements, that it is an emergency and it needs an intervention. Okay, thank you very much, Miri. Miri Ha? You say it like that? Miri Ha?
No, it's just, you can just say Miri.
Miri,
yeah.
Okay. So thanks, Miri. Next group, can you complement? They've analyzed some aspects that can justify an intervention, but I would like to add more elements. Maybe the second group can say things that were not mentioning before. So to complement the information that Miri has given us.
Well, I think we can add that if you look at the data real quick from 2016, which was an outbreak as well, then there are more cases in week 34, which is the beginning of the spike, and in week 40, which is the highest point in 2018, than 16. So you can consider it to be an outbreak from that point of view. And also in the healthcare system, there was another problem, is that they were treating the malaria with a certain treatment that doesn't apply for the one case, the one type of malaria that is happening right now, the one type of virus.
So the treatments that they're using in some areas, which is Fansidar or chloroquine, which are old anti-malarial treatments that are not effective anymore, are being boosted outside, right?
Exactly. So that can
that's
like
a very important element as well.
Yeah, that
Yes?
can like false the data because you think those people are now immune and vaccine and they're not. So yeah, it's an additional problem.
So what happens with these treatments is you give them to the population and it's not working. So they're not going to get cured. They can die from malaria. Yeah, so that's an important element. Any other elements that you have looked at apart from the data and the treatment issue, which is very important, both of them?
Yeah, also that the treatment and the cost for the ambulance in the more severe cases were quite costly for population that don't have enough means and resources. So that can also add to the fact that MSF should intervene because they have the means to provide healthcare for free.
So the access to free care is one element, and also the referral system, no, to link the communities to the primary healthcare or the hospital. If they need to pay the fuel, or if there's not an existing ambulance in place, then the patients will arrive very late in very bad conditions, right?
Exactly,
and this leads also to a high mortality. Okay.
Exactly.
Other elements, Julian, in your group? Any other issues? Okay, so we jump to the next group. Other things to complement your previous colleagues. Who's the representative of the group?
I'll go ahead and people can jump in then. So we also saw the case fatality rate was also more than 10%. So we consider that also as an emergency. And the healthcare system, like as mentioned, is not adequate, and there is really bad case management because they're treating fever as malaria. And there are irregular cases. So we would have an outbreak investigation to see why they're irregular. And we would also look at the population below 5 that are more vulnerable. And like mentioned, alternative medicine is being used, which is not really effective. They're using even traditional medicine as the first option. So that's again a problem.
Yep, very important. So we need to know the cultural elements and where is the people looking for health. What are the health-seeking behaviors of the populations? Are the people that are not having access to proper diagnosis and treatment, going to the traditional medicine or the local pharmacies to get the medicines, right? Thanks, Trigala. That's a very important element to look into. Okay, other elements.
Yeah, and then the quality of confirmation is also, confirmed cases is also, basically the suspected cases are based on symptoms. So that's again another problem. If anybody would like to add, if I missed out on anything.
Okay, so just to complement the information that you've given, which is quite well analyzed, we've got different conclusions here in malaria. Yeah, the epidemiological curve is increasing and not yet peaked. But do we have an unclear epidemic? We don't know yet because we don't have. As a group of Julian, we're trying to gather information of previous years and try to decide where is the threshold. Normally in epidemics of malaria, it's very difficult to have accurate data. Like in an ideal scenario, you will have 5 years of retrospective data to determine the thresholds, yeah? And this is a very epidemiological with a formula that will give you the very nice pattern. And if it goes outside that threshold, then you will have an epidemic. In real life, in the project, when you're working in the field, you will not have that accurate data. Like we've done so many assessments in the Congo, in the middle of nowhere, and the ministries of health or the peripheral health posts or units, they don't have accurate data. So you're quite blinded in terms of malaria. What you need to understand are all these contextual elements to figure out if you are confronted, and we don't say it's epidemic, but with an emergency of malaria. And this is what you need to think when we talk about malaria emergencies, different from other epidemics, like in meningitis is very clear, the epidemic definition, or one case of measles in a camp, that can be, when you confirm the cases, that can be an epidemic declaration, right? So there's a little bit of a difference with malaria. When you have massive number of consultations, the staff is overwhelmed and you cannot cope, that's one of the signs that you need to think about emergencies in malaria. The poor quality of case management, you've mentioned it, no? You've got both diagnosis and treatment failing here. You've got lack of RDTs or expired rapid tests. You've got treatments that are not working anymore. People need to pay for them. So there's a poor quality of case management. And on top of that, the human resources are not skilled enough and they're not trained enough to manage these cases. There's a low number of human resources, they are unskilled, and then the supplies are not enough, yeah? It's mentioned that there's a very lack of supplies. UNICEF and the Ministry of Health are trying to provide some RDTs and ACTs, but it's not arriving. So that's an issue. And on top of that, in the emergency preparedness plan, there were not, it was not the scenario of malaria as a possible emergency response scenario. So there's not supplies even at the NGO level, no? There's a late arrival, there's a farming period, so everybody's in the fields, and there's no awareness of the importance of arriving late. Having malaria can have consequences leading to mortality, no? The traditional medicine that you have mentioned and the referral system, where we're talking about what the group of Julian mentioned as well, of not being able to be transported on time to the hospital. The local response capacity is collapsed. Remember we were talking, when Mark was telling you about the priorities, when you have the gap, the humanitarian gap, when the local response is not coping and the regional response has no capacity, then there's a big peak of mortality and you need to really intervene as fast as you can. So is this an emergency? There's a high seasonal transmission with a large magnitude of cases, so all the structures are collapsed. There's a high mortality. Remember, the threshold for malaria in terms of case fatality rate should be under 10% to be playing in the right path of quality of care. Because remember, the case fatality rate is measuring 3 things, which is, you tell me, if you remember that. Case fatality rate? Someone? What does it measure?
How lethal is the disease and the capacity of the healthcare system in terms of case management and access? Exactly.
So access, quality of case management, and the severity of the disease. Yeah, we have case fatality rates in Ebola of more than 50% because of the viral severity. In malaria, with all the studies that have been published, less than 10% is the severity that malaria is going to happen. So you can do better than what we have in Niger at this specific moment. Yeah. So just to structure your heads a bit, no? Is there an emergency humanitarian need? Yes. There's a large magnitude, a lot of people affected, and with high mortality. And we're not talking about the case fatality rates in the hospital. Remember, there's a lot of, in the community, there's signs that there's something going wrong. Have you read about it? Someone can tell me what is happening in the community in terms of mortality. I don't know if you flagged it in the text. There's someone, or should I jump in? The small graves in the communities. That means children are dying. There are fresh graves there. Have you read that one? So when you see fresh graves, small graves, something is going wrong, very wrong, yeah? Not only at hospital level, but at community level. So does it need an intervention? The local capacity is collapsed. Do we need to intervene? There's no external actors. You haven't mentioned the actors present in the field. Apart from the MOH, do you remember which other actors are there? Come on, tell me.
I think UNICEF was there.
UNICEF was there. What is UNICEF doing?
They had distributed some amount of
other actors. In the meantime, Srivala reviews what UNICEF is doing. Other actors. There's another international NGO in the field doing something.
ACF?
ACF. ACF, what are they doing, Sinead?
I think some nutrition thing.
They're doing nutritional programs. They're doing ambulatory treatment centers and intensive care units, nutritional centers in the area. Yeah, so there's someone covering the gap of malnutrition in these moments. But what is happening with ACF? Do you remember?
And the project is going to finish on the 31st.
Of the year, yeah?
Yeah, oh sorry, I was thinking week 31, never mind.
Yeah, so they're closing the projects. So there's going to be another gap there. And malaria and malnutrition, it's a really, really bad combination in terms of comorbidity. Malnourished children with malaria, they have worse chances of survival if we don't treat them properly and on time. So we need to take that element into account. Who else is working in the area? There's a UN agency apart from UNICEF working in this area.
Is it World Food Program?
Yes, WFP. So they're doing food distributions. And what is happening with them?
I think they are not very sure whether they will continue their program next year. They're winding down their program. Yeah.
So that's another sign of alert that we need to take into account. So we are in a, and you will learn this a lot with Nuria on Friday. So when we're talking about nutrition or malnutrition, you need to look at the context. So there's a lot of food insecurity in these areas. So the prices are rising up. You've got the hunger gap of food in this period of the year that is at the same time as the rains and as the malaria, right? World Food Program is distributing food during this period, but they're not sure if they will continue, and ACF are going to close down the projects. So we are in a bad situation now, but this can be even really worsening in the coming weeks or months. So we need to make a projection again of what is going to happen in the coming weeks. Yeah, so it's a very important element. And then the ministries of health, they're completely overwhelmed and they don't have the capacity. It's a structured program of Niger. Yeah. So I think we've touched all these things. So what do we want to achieve really here is to increase the recovery of patients of all ages, because we've seen these trends of the over 5s. In malaria, in Niger, you see that you can have exceptional peaks affecting to more populations, and this is linked to immunity, and we will go through that. And we're going to treat all ages affected by malaria and reduce the transmission of malaria in all functioning health facilities in Busa. So remember that map I was explaining you in the video. If you see Niger, how it is located here, it's one of these countries that have 4 to 6 months transmission, yeah? And this country is prone to epidemics because when you are not exposed along the whole year, then your immune system is not that strong, or that strong, strong in terms of immune response to the parasites. So you're not bitten so many times a year, so your body, in a way, forgets about the parasites reaction. So that's why these areas, we need to take these elements into account, and you can have exceptional peaks, very, very high, leading to high mortality in these specific areas of Africa. Okay. Also in the rest of the areas, you can have a lot of emergencies due to other factors, lack of access, geographical barriers, exceptional years due to heavy rains, etc., etc. And all these triggering factors, we need to take them into account. Okay. Any questions concerning that? Okay, I don't see any. Oh, there's 2. Oh, sorry, you were answering to my questions. Yeah, I'd rather have you on the unmute modus, so we go faster. Okay, so this is what happens. So in the exercise 2 that we're going to do it very fast in plenary, we need to write recommendations for a malaria intervention with the project purpose and expected results. So what would you define as a project purpose here? And what would be your main lines of an intervention of malaria? Because we have the central problem is the malaria, right?
Yeah, so we need to reduce the mortality and reduce the spread.
Exactly. So what are we going to do to reduce mortality? Remember the main pillars of an intervention of malaria? What are we going to do? After the analysis of the situation, what can we do to reduce mortality?
So it includes both of the curative interventions and the preventing one, I guess.
Yes.
With management, surveillance.
Exactly.
Vector control kind of thing.
Okay, so we will go through those aspects together, right? So what is the project purpose? As you were mentioning, malaria-related mortality will be reduced in Busa district, and the expected results are to do early diagnosis and treatment of non-severe malaria is improved, and also we need to do something about the severity, the severe cases, right? There's a lot of issues that we can work about. The preventive activities to limit, control the spread of an outbreak needs to be implemented, and also the surveillance, and all of them has been mentioned to you by you. So very nice. Thank you very much to all of you. So which are the major lines of an intervention of malaria? Remember the coordination. You need to talk to the authorities and tell them what you're going to do. You need to push to WFP to continue with the programs. You need to push ACF to continue with the projects because of the overwhelming situation. You need to talk to UNICEF for supplies, etc., in a coordinated way, right? Surveillance, we need to reinforce the surveillance systems from the communities up to the hospital at all levels of care, and follow up the indicators. Yeah, so the surveillance system, super important to restructure it from the day one of the emergency. Then the community engagement and health promotion. Loads of traditional medicine, fake or on substandard drugs on the market that are effective for malaria. People need to know what is malaria and how they can come to the hospital for free access of healthcare. So gratuity free of care is very important in emergencies. Yeah, and then we'll have the preventive and curative aspects. So all these elements in place. Again, for the surveillance systems, we need to do the data collection weekly, and we need to look at the RDT positivity rate in malaria and the total number of malaria cases split by age groups in emergencies. So we need to look at the under 5s, the 5 up to 15, and the over 15, and look at these proportions of malaria morbidity comparing to other diseases, so that we see how overwhelming is malaria. And then, of course, look at the quality of care. Total malaria diagnosis should be case definition of malaria with the RDT or microscopy for confirmation. And then we will have the confirmed cases in a coordinated way, and everybody should report in the same way, the Ministry of Health and the international actors or local actors, all of them. Then the case fatality rate of malaria should be below 10%. And when we have all these elements and indications, then we will need to respond. So we have, as we've mentioned, these increased absolute numbers of confirmed malaria, and we need to do this follow-up of screening activities in the different programs, and we need to reduce this mortality. How will you organize the patient management to do it better? We've got 10 more minutes, so I want you to be very fast. What would you do to improve the patient management in this situation in Niger? What would you do? Think about all the levels of care. Think about the community, the primary health care, and the hospital. How would you improve this?
I'm not sure if this is applies to malaria or not, but maybe as MSF tried to coordinate with the governmental health facilities to take to organize mobile healthcare spots or facilities closer to the rural areas, so they won't spend a lot of time in just try to arrive to the hospital.
Yeah, it does apply to malaria, but instead of mobile clinics, I would say decentralization of care. Remember that you go to the communities with community health workers, and you do the diagnosis and treatment on the ground. Like that, you can detect a lot of simple cases, not severe, but also you can have the opportunity to find out the severe cases in the community so that you can refer them to the hospital as soon as possible. Yeah? So do you remember what we do with the severe cases in the communities before we actually take them to the hospital? Because there's one thing we can do for them to reduce mortality in malaria.
We give them that kind of special medicine, but I can't remember its name.
Remember the suppositories, the rectal artesunate? When you have a severe case, like a baby that is completely sleeping with no reaction, with a lot of fever and no appetite, cannot swallow, these are signs of severity, yeah? So you put the rectal artesunate, so you don't need to be qualified as a community health worker. You don't need to be a nurse or a doctor to introduce a suppository in the baby. And this is artesunate, which is the antimalarial drug that will be used later in the intravenous of the hospital, so that they can start improving, because already with this medicine, the parasites are being killed. And then you do the complete IV treatment at the hospital level. Yeah, so in the community, the centralization of care is one of the key elements in malaria. Then to bring them to the hospital, what do you need apart from the rectal artesunate?
And we need to ensure that free transport is provided. So like I think at the moment the citizens are being charged for the use of the ambulance.
Yeah, so we need to build up the referral system, no? This has been mentioned by you. And what else? Other elements like the severe patients, they had a lot of problems with what? Once they're in the hospital, we had a lot of problems. We've mentioned it, but just to refresh it again. What do you do for case management in severe malaria patients, apart from the medication that you use for the severity?
Maybe you need to make sure that in the hospitals there's access to care 24/7, so that there's always
that's very important, Miri, very good. But 24 hours, 7 days a week. But you need a specific care for severe patients. Remember?
Blood transfusion?
Blood transfusions, thank you, Gier. Yeah, so what happened in this case? Remember, they were having to do proper blood transfusions. You need to test the blood of the donors, right? It's very difficult to have blood banks in African settings. You need a cold chain which is stable, and in this specific case, remember when reading the case, there was a lot of cuts of cold chain ruptures constantly. So you need to be careful with those things in the lab. So if you don't have a constant cold chain structure, either you reinforce this and you put generators, or you build something, logistically speaking, to have a stable cold chain to try to store the fresh blood that can stay in the fridges for like 20 days. And then you need to do also campaigns of blood before actually the season, so that you can have some storage blood. But if you don't have the testing for from the rhesus group, if you don't have the testing for hepatitis B or C or HIV, if you don't have all those tests, then you are not going to be able to perform quality blood transfusion services. So this needs to be in place, and you need to ensure that, because there's a lot of people that are going to die of anemia in malaria, a lot of children. And also it said in the text that they were overusing the blood transfusion services. So some kids had transfusions without the criteria. So again, reinforcing trainings to the staff is very, very important. Yes? So this is what we can do. The referral system to be in place to link the peripheral level with the hospital. The supplies are very important. We need to supply with RDTs and antimalarials. The staff needs to be increased, and not only increased, but skill them with trainings and supervision. Then refer the complicated and severe cases with the pre-referral treatment. And as we said, the safe blood transfusion capacity, and maybe build up circuits and flows in the hospital to do a better job in terms of having a well-synchronized way of treating patients at the hospital wards. So what will be the vector control strategies? Do you remember if there was something done at that level in terms of vector control? Some actions were done in the text. Did you remember? What was the situation? Huh? Long-lasting nets were distributed, right?
Yeah.
So Sridhala, are we happy about that? Are they doing it properly? Are they using it properly?
Yeah, we need to make sure that they do it properly, not just like use the net for fishing.
Yeah, exactly. Else. Remember the exercise we were doing in the videos. There's a lot. Those photos were real. We've taken those photos from the fields, and there's a lot of lacking. There's a lot of distributions that you can see result in the market or bad use. So health promotion activities needs to be constantly done, and even do supervision activities or follow-up activities. So the mass distribution was done, but and then in the residual spraying was done at the hospital level, but not done at the community level. And this needs to be done in advance before the season actually arrives. So the health promotion activities needs to be constantly done. And what about all the preventive strategies in Busa, which is the Sahel area where we do malaria chemo prevention? Normally in these specific areas, you can do SMC activities that will reduce drastically the burden of malaria in these specific cases. So before next year, we should anticipate and do an SMC activities, but not now in the middle of the emergency, because it's very difficult to do it and you need to put all the children on the 5, and that's a lot of burden in terms of logistics in the middle of an emergency. But you could also think about other preventive activities, right? Once you're doing different things, maybe you can profit and do more screening as well if you're doing in the communities some assessments for other issues. So remember that in this specific case, MSF did not have an emergency preparedness plan for malaria, and then it needs to be built up again. So needs to the surveillance system needs to be rebuilt with the case definition and reporting, the supplies, the vector control, the number of staff, and the referral system. So these are the major elements with health promotion and community engagements, right? So remember that in malaria emergencies, we need to focus when we have a big outbreak of malaria or a big emergency, that the high burden regions will be affected mainly by the children under 5, but during epidemics or big emergencies, the whole population will be affected, either because of population movements or because of the seasonalities and endemicities of the areas where we are. So the triggering factors for that are increase of vector-related issues. Remember, in this specific context, the rains came before, the stagnant water was all over the place, breeding sites all over the place, so there's a lot of multiplication of mosquitoes and high density that can lead to more transmission to malaria, yeah? So all these triggering factors need to be taken into account when we do an outbreak investigation, as all the steps that Nuria explained you last week. And of course, malnutrition and other epidemics need to be taken into account. Yeah, like in Ebola outbreaks, normally this happens in Africa, sub-Saharan Africa, where malaria is also endemic. They have similar signs and symptoms. So normally when we have an Ebola outbreak intervention, we treat systematically for malaria to avoid confusion and to reduce the risk of mortality in Ebola patients. So we do things like that. And then we need to monitor if the antimalarials used are efficacious or not. Like in this case, they were using fansidar and chloroquine, but also ACTs now are, as I explained you in the videos, there's been a raise of resistance of ACTs in the Mekong region. So again, we need to do increase the capacity of the health services, the decentralization of care. And I'm just repeating myself just so that make things clear. Link the community with the hospitals, with our referral system, with the safe blood transfusion capacity, reduce the case fatality rates, and vector control measures are needed to be in place. Preventative aspects and curative aspects always needs to be together in all the outbreaks response, not only for malaria, but for all the diseases, okay? So I think it's 11:35, I'm sorry. Maybe you could, if you have any questions, maybe we can have a few more minutes just for clarification. So there's, will the presentation be, yeah, I will put the presentation as we finish, I will send it and I will put it in the Blackboard, so no problem, yeah.
I have another question. I hope
yes.
It won't take too long, but
no.
It may be also a political kind of question. So if the governments of these specific countries or these specific areas, they always know that their population are vulnerable, or that kind of epidemics or diseases usually had their countries on specific times. Why they are not preparing, or why they are not, for example, coordinating even with the private sector or the NGOs in advance? So is it?
Yeah, it's a very pertinent question, Silvia. I mean, it's very difficult. We've been working in Niger since ages. When we started, and I can recall, I was a medical emergency coordinator back in 2005 because of a nutritional crisis, right? And there was a huge peak of malnutrition cases. All the MSF sections were there. And this is a structural problem. There was the hunger gap season is always recurrently happening in Niger. We know that there will be a hunger gap. We know that there will be a malaria season. Sometimes these issues goes beyond the capacity because of whatever reason, because of heavy rains, because of increase of prices in the market, food security issues, conflict issues. Niger has been knocked down not by COVID-19, but by insecurity in that region, bordering Burkina Faso and Mali with all the Islamist Al-Qaeda's groups. So there are so many structural problems in Niger, which is one of the poorest countries in the scale of the world, that you may foresee that things can happen. And things will happen, but sometimes it will go beyond the scope of what it was predicted, if you know what I mean. So in 2005, I saw villages of malnourished children. It was amazing. In 2010, there was a huge exceptional peak of malaria, and it was overwhelming for all the teams. In 2012, it was even worse than 2010. So you cannot even predict how many years it's going to happen until this happens. So you might be ready in those specific contexts, which are so poorly structured with no capacity, that this is why we do the emergency preparedness plans, so that to anticipate to these scenarios, to be able to be reactive. Yeah, but very difficult to predict. And sometimes what we did in Niger, and this is the modus operandi of MSF in Niger, is that you work like a normal project the first 6 months of the year. So from January to June, you're with a normal project with your human resources completely planned. And from June to December you are working in an emergency modus operandi because of malaria, malnutrition, and all the different other emergencies that may pop up. Like I said, like conflict areas, meningitis outbreaks, measles outbreaks, cholera outbreaks, no matter what you do, right? So teams need to monitor the food insecurity situation. Teams need to monitor the epidemiological trends of the different diseases that are prone in that specific area of the planet, and then be reactive and have all the stocks prepared with teams to support the Ministry of Health that will not have the capacity. But for years, just to be fair, since 2012, there's been planning seasonal malaria chemoprevention activities, and this is giving the anti-malarial drugs to all the children under 5 in all the Sahel region for different countries. And there's donors that are giving money to all these countries that have not the capacity otherwise. So you have Malaria Medicines Venture, Malaria Consortium, PMI, Global Fund, and all these actors that are giving specific money, and not only money, but resources, training materials, and monitoring and evaluation and research activities in the frame of WHO scope of reducing malaria worldwide. So there's more funding coming for these specific programs, preventive programs that are reducing the incidence of malaria and is reducing the mortality because of this preventive effect in the most vulnerable children. Did I answer to your question?
Yeah, yes.
Okay, thank you for it. It's very pertinent. Any other questions?
Sorry, it has nothing to do with the malaria. It's about tomorrow's session. Because I will be traveling, and I see that you're recording now. I don't know if I can ask you to record tomorrow's session so that I can maybe
who's doing tomorrow's session?
Mark, I think.
I'll ask him to record it for you.
Yeah, so if it could be possible to record it, because maybe I can watch part of it, but I'm not even sure because of the internet connection.
Okay.
So yeah, I would like to watch it later if possible, if it is okay, of course.
Yeah, I'll ask Mark. No problem. What do you have tomorrow with Mark? I don't remember the sequence.
Cholera is
tomorrow? Oh, cholera. Okay, so cholera with Mark. Okay.
Yeah. Thank you so much.
Yeah, that's an important session, so that's good.
Yeah.
That you follow. Yeah. Okay.
Thank you.
Any other questions? Okay, so I think we're 10 minutes ahead of your time. I appreciate your availability and your flexibility and your participation. So I hope you enjoyed the session, and well, we could be always in touch for through forums or through the platform in case of needs. And I hope you enjoy the rest of the training as well. Okay. So thank you to all. For me, it's very important that you have like a structure, no, in your head when you want to respond to the emergencies. See that we do everything with the logic for action, no, to make operational decisions and to try to reduce mortality at the end of the day.
Thank you very much. I like it a lot. Thank you.
Oh, thank you, Elena. Thank you. Bye-bye.